Varun, can you just pass the host rights to me? I'm not able to share the screen. Ujjal or Varun?
Done, sir. Done.
Life is beautiful.
Dr. Mushmi,
The world we
I believe
live
it is
in,
audible to you.
the air we breathe, the happiness we share. Imagine it all coming to an end.
Ujjal, is it audible?
Imagine the cruel hands of a deadly
Yes, it's
killer
audible.
snatching it all away. A killer named cancer. Cancer, the dreaded C word. Lung cancer, the most dreaded of them all. Lung cancer is the major cause of cancer-related deaths worldwide. More than 100,000 people are diagnosed with lung cancer every month. Much more than any other type of cancer. How does cancer develop? Immune evasion leads to cancer development and progression. Increased immunosuppressive mechanism leads to decreased immunosurveillance. Current therapy. All effective therapies improve immune function. Chemotherapy decreases immune suppression, increases immune activation, and is synergistic to immune therapy. Desmocollin 3, DSC3, is diagnostic of squamous non-small cell lung cancer. Chemotherapy converts DSC3 negative to DSC3 positive cells. It is also expressed in other cancers like melanoma, colorectal cancer, besides many others. The emerging treatment, Mycidac-C. Mycidac-C is active immune therapy targeting DSC3 expressing cancer. Mycidac-C activates immune cells and expresses DSC3 on their surface. Mycidac-C reduces immunosuppression by its effect on immunosuppressive cells and cytokines. It preferentially kills DSC3 expressing cancer cells. Mycidac-C provides synergy to chemotherapy. All this backed by solid research and innovation. Randomized controlled clinical trials have been conducted wherein Mycidac-C is added to standard chemotherapy to evaluate its safety and efficacy. Research studies have proven that addition of Mycidac-C does not add to toxicity. Addition of Mycidac-C improves response rate. Addition of Mycidac-C improves overall survival probability by 28.2%. Improvement in survival in squamous non-small cell lung cancer (NSCLC) is 43.5%. This is significantly better than most other therapies. The future, Mycidac-C, a game changer in the treatment of lung cancer. Cadila Pharmaceuticals' extensive research relating to the treatment of lung cancer has brought a smile to many a face. All this would not be possible but for the vision, persistence and foresight of Shri I.A. Modi. His thinking was very clear. Anything that can add to a moment of life and make it more meaningful is definitely worth the effort. Mycidac-C offers that hope for life. Mycidac-C is the first active immunotherapy targeting DSC3. It can be used as a standalone for small tumors. It works in synergy with chemotherapy for large tumors. Mycidac-C, the revolutionary game changer for treating lung cancer.
Thank you for paying attention. So let us talk science upon the molecule. I hope it is visible to you. I hope it is visible to you. Perfect. So this is regarding the presentation of immunotherapy used in the oncology. So this is the picture to tell you about the history of usage of the chemotherapy and the immunotherapy in the field of the oncology. So when I talk about the chemotherapeutics, it started in around 1942 with the discovery of the nitrogen mustard as an alkylating agent, followed by the discovery of methotrexate, vincristine, doxorubicin, tamoxifen. So at the moment, there is an era of using the tyrosine kinase inhibitors for the multiple number of malignancies. But when I talk about the immunotherapy, the history of the immunotherapy is not old in comparison to the chemotherapy. It was started in 1986 with the usage of the interferon alpha, and followed by the BCG to be used in the cases of superficial bladder cancer, followed by the discovery of the trastuzumab to be used in the cases of HER2 positive breast cancer, followed by the CAR cell therapy, followed by the Sibuleucel-T, ipilimumab, and in 2013 we got the approval of Mycidac-C to be used in the cases of the metastatic non-small cell lung cancer, which we are going to be discussing here. So to talk further upon the immune mechanism and the cancer, as we do understand, there is a elimination phenomena is there, and there is a lack of the positive signals are there, and because of the deficiency or use of the sorry, thank you. So because of the lack of the regulatory cells here, we do understand like nature killer cells lost, CD8 plus regulatory T cells here, and there is a escape phenomena is there, and that is why this is giving the chance for the this tumor cells to grow day by day, and ultimately taking the life of a person. To talk further upon the molecule Mycidac-C here, as we do understand, this has been done and proven in the laboratories of the Kerala Pharmaceuticals that Mycidac-C induces the expression of the desmocollin-3 on the surface of the T cells, immune cells. So, giving the single injection will be creating the expression of desmocollin-3 on the surface of the T cells, and giving the multiple injections here, there is going to be the better levels, more expression of desmocollin-3 on the surface of the T cells. So when I talk about the cytotoxic effect, since there has already been there is an expression of desmocollin-3 on the surface of the squamous cell variety of the non-small cell lung cancer is there. So there is a more cytotoxic effect is seen with the Mycidac-C in comparison to the adenocarcinoma, where the expression is low, which has been proven by the number of published literature, which again I'm going to be elaborating here. So talking upon this further, chemotherapy and the desmocollin-3, we do understand chemotherapy do convert desmocollin-3 negative cells to desmocollin-3 positive cells. So this has been done with the chemotherapy, even with the subtherapeutic doses. So as we do understand, like cisplatin, paclitaxel, doxorubicin, gemcitabine exposure will be converting the desmocollin-3 negative cells to desmocollin-3 positive, which has been possible even with the 1/10 or subtherapeutic doses. To talk further here, this is the mode of action of Mycidac-C. It induces the expression of desmocollin-3 on the surface of the T cells, and desmocollin-3 expressing immune cells kill the desmocollin-3 expressing cancer cells, and desmocollin-3 is the marker for the squamous variety of the non-small cell lung cancer. And desmocollin-3 negative cells express desmocollin-3 following the chemotherapy, which is possible even with the subtherapeutic doses. So this is regarding the details of Mycidac-C. As I told you, this is the innovator product from the Kerala Pharmaceuticals. We people actually developed the molecule, and it is having the strong immunomodulator activity. And here it is available with the as an pre-filled syringe of 0.2 ml, and here 0.1 ml is containing the heat kill micro W with the dose of zero point 0.5 multiplied by the 10 to the power 9 bacilli, and sodium chloride is being added here as an excipient. And talking about the preservative here, it is containing very low quantities of the thiomersal. So this is regarding the sites of administration where the intradermal injection can be given. So first is going to be like at the level of deltoid region, it can be given. Secondly, at the suprascapular region, it can be given, and third side being the periumbilical region, and it can also be given over the inner part of the thigh. So this is regarding the detection of desmoglin 3 expression upon the tumor cells, which has been shown here. Immunohistochemistry using the commercially available antibody stain. So this was the literature which I was talking to you regarding the different types of histological types of non-small cell lung cancer, which are having the different levels of expression of desmoglin 3. So we look upon the this second column here upon the non-small on the squamous cell cancer. So what et al, Kim et al, Ted Sommer, Suta, Monica et al. And if we are going to be combining all of these studies, it let me show that in 86.25% all of these cases, the squamous cell non-small cell lung cancer will be having the expression of the desmoglin 3. So desmoglin 3 is the marker for the squamous variety of non-small cell lung cancer. And when I talk about the adenocarcinoma, the expression is very low, very low. Like when we compile all this data of published studies, there is only 0.45% expression of desmoglin 3 is there. When I talk about last cell carcinoma, there is an expression of 11.22% after compiling all of this data of published studies. So desmoglin 3 is the marker for the squamous non-small cell lung cancer. So more expression is seen of desmoglin 3 in this histological type. So this is regarding the clinical studies which have been done upon the Mycidac-C in the patients of advanced non-small cell lung cancer. So I'll be initiating the discussion with the this pilot clinical study which was done early. So it was open label randomized controlled clinical trial of desmoglin 3 targeted toll-like receptor agonist Mycidac-C, a micro W in the advanced non-small cell lung cancer. So post randomization in the chemotherapeutic arm, the platinum was used with the dose of 75 milligram per square meter of body surface area, and along with that, etoposide was being added with the dose of 100 milligram per square meter of body surface area for the cycle for 6 cycles. And in the study arm, along with this chemotherapeutic, the Mycidac-C as an immunotherapy was being added. And here the dose was 0.1 ml every fortnightly for the period of 6 months. The injection was used. So this is regarding the demographic patient characteristics in these patients. So both of the arms were similar in nature with respect to age of the patients, sex, performance status, Karnov score, stage of the disorder. So all of these patients were who were recruited, they were actually been having the stage 3B or the stage 4 disorder. So to talk further upon the outcome of this clinical study, the response which was found with the immunotherapeutic arm Mycidac-C was 11% better versus the chemotherapeutic arm, where it was found to be only 27%. So when I talk about the patients who actually progressed with the disorder, so there were 19% of cases who were upon the immunomodulatory arm. They progressed with the disease, and there are more number of patients who were upon the only chemotherapy. There were found to be more progression of the disorder, and there was a case of complete response was seen in the treatment arm, but none in the case of control arm. So to talk about the adverse degradation profile, both of the arms were similar in nature, or in some of the cases, the Mycidac-C arm immunomodulator arm was having the lesser number of adverse degradations versus the control arm or chemotherapeutic arm. So to talk further here upon the approval clinical trial of Mycidac-C, this was open label, randomized controlled clinical trial of desmoglin targeting toll-like receptor agonist Mycidac-C in combination with paclitaxel plus cisplatin versus paclitaxel plus cisplatin in the advanced non-small cell lung cancer cases. So post randomization in the control arm, the platinum paternity doublet was used with the dose of paclitaxel 175 milligram per square meter body surface area, and the cisplatin 100 milligram per square meter body surface area, and each 21 days cycle. And in the immunotherapeutic arm, along with the chemotherapeutics, the Mycidac-C was used as intradermally. So it was initiated as 0.2 ml a week before the first day of the chemotherapeutic cycle. So 0.1 ml was given upon the one arm, and another 0.1 ml was given upon the other deltoid region. Subsequently, 0.1 ml was given on the 8th day, and the injection was repeated upon the 15th day. For subsequent cycles, only 2 injections were used. This 8th as well as the 15th day cycle injection was given, and all these patients continued for the 4 chemotherapeutic cycles. So statistical analysis were done with the Cox-Mental chi-square test, and the safety parameters were being recorded for the study in the terms of percentage and proportions, serious as well as the local site reactions. And talking about the eligibility or the inclusion criteria, all these patients were being suffering from the stage 3B or either the stage 4 non-small cell lung cancer. And age was 18 or 18 plus, echo criteria was 0 to 1, life expectancy were 24 weeks or more than that. And hematological parameters, absolute neutrophil count was 1500 per cubic millimeter of blood or more than that. Platelet count was 1 lakh or plus, or hemoglobin was 9 gram per deciliter of the blood or more than that. Similarly, the hepatic function, renal function test, CM creatinine was 1.5 or lesser than that. Pregnancy was ruled out before participating into the clinical trial. Further informed consent from all these patients were taken out. So talking about the demographic characteristics of these patients, both the arms were equal in nature. But when I talk about the outcome here, so when I talk about the progression of disease, it was found to be like in 7 cases with the Mycidac-C arm, they actually progressed with the disorder. And in the chemotherapeutic arm, 5 patients, they progressed with the disorder. And death, 90 number of patients, they had the death with the Mycidac-C immunotherapeutic arm. And there are more number of patients who had the death in the chemotherapeutic arm. And loss to follow-up or consent withdrawal, they were like 24 in the Mycidac-C arm, 98 cases were there in the control arm. When I talk about the histological types, all these types like adeno, squamous, other types, and large cell, all types were recruited for the study. Talking about the outcome of the clinical study, when I talk about overall response, like 10% advantage was seen with the Mycidac-C arm versus the chemotherapeutic arm. Here it was found to be 37%. In the immunotherapeutic arm, it was found to be 47%. When I talk about the progressive disease, like 11% of cases who actually persist with the disorder, so it was 5% better with the chemotherapeutic arm. So 16% of cases with the platinum-containing doublet arm, they were progressed with the disorder. And 3 cases of the complete response were seen with the immunotherapeutic arm, Mycidac-C, but none in the case of control arm. So it was concluded that addition of the Mycidac-C, it improves the response rate. And there's the Kaplan-Meier curve to talk about the progression-free survival of the patients who actually completed the 4 cycles of the chemotherapy. So when I talk about the immunomodulatory arm, there was found to be 96 days advantage was seen with the Mycidac-C arm, and hazard ratio was found to be 0.43 in these patients. This is the Kaplan-Meier curve for the patients who complete the 4 cycles of the chemotherapy overall survival. So mean survival time for the Mycidac-C arm was found to be 299 days versus the control arm 233 days. So 66 days advantage was seen with the immunomodulatory arm, and the hazard ratio was found to be 0.64 in these cases. So to talk upon the overall survival in the patients who complete the 4 cycles of chemotherapy in the squamous variety of advanced non-small cell lung cancer. So here it was found to be best output after the conduct of this clinical study. So Mycidac-C arm, there was seen to be 100 days advantage in comparison to the platinum containing doublet arm, and the hazard ratio was found to be best here to uh, uh, be seen as 0.40 in these cases. So talking about the adverse degradations here, hematological and the non-hematological. So both of the arms seem to be equal in the with respect to anemia, leukopenia, neutropenia. Talking about the non-hematological toxicities, there were adverse degradations found to be lesser with the immunomodulatory arm, seen as dyspnea, diarrhea, nausea, vomiting, as well as some case of fatigue was seen. So to conclude here, Mycidac-C immunomodulators seem to be synergistic to the chemotherapy. It improves the progression-free survival with the hazard ratio of 0.43. It also improved the overall survival in these patients with the hazard ratio of 0.64. And in the squamous variety of non-small cell lung cancer, hazard ratio was found to be 0.40. And actually, all of this immunomodulator therapy is not been associated with any kind of the systemic side effects. But some cases of the local side reactions, like injection side reactions, were found in these cases, which were actually self-healing here. So this was found to be in patients who completed the 4 cycles of the chemotherapy. And would like to tell you, this clinical study has been published by Dr. C.P. Chandra Belani, as well as our R&D head, Dr. Bhaglesh Kamar, who is present here. So this study states that in the subgroup analysis, improvement in the median survival by 127 days observed in the squamous non-small cell lung cancer with the chemoimmunotherapy with a hazard ratio of 0.55, and patients with receiving the planned 4 cycles of chemotherapy, there was improved median overall survival by 66 days uh, with a hazard ratio of 0.64 in chemoimmunotherapy arm compared to the chemotherapy group. And this was associated with the improvement in the survival by 17.48% at the end of the 1 year in the chemoimmunotherapy arm. And the systemic adverse reactions were found to be identical in both of the groups. So to talk further here, there was a number of studies, some data has been generated upon the bladder cancer, superficial bladder cancer, in which I would like to elaborate here as well after a couple of slides. Secondly, upon the ovarian carcinoma, colorectal carcinoma, talking about the malignant melanoma, some preclinical data is already been generated, and some data is also being generated in the meningioma as well as in the cases of the head and neck cancer, which I'm going to be again elaborating here. So this was presented in the ESCO, which says like median overall survival was 236 days in the control arm, and there was an improvement of 59 days to 295 days in the KD05 with a hazard ratio of 0.55, and there was no significant difference between the adverse deviations in the both of the arms. So this was being presented and published in the medical oncology. So this is another one in the world, which was presented in the World Congress lung cancer. So high compliance rate was observed in the patient with the patients receiving the KD05. It improves the response rate and median survival when administered to the adjuvant as an adjuvant to the chemotherapy. So this was which I was elaborating here. So it was published as a comparative evaluation of microbit W vaccine based immunotherapy plus concomitant chemo radiation versus the concomitant chemo radiation alone in the locally advanced head and neck cancer. So this is recently been published in 2018. So this study on the Indian locally advanced head and neck squamous cell carcinoma patients says the use of the weekly MyoW vaccine plus weekly cisplatin is safe, and microbit W with concomitant chemoradiation may be superior to the concomitant uh, radiation therapy alone in the patients with the better response rate, higher local region disease with a lesser toxicity. So it is definitely going to be adding here with the concurrent chemoradiation. So this was another publication by Dr. M.C. Pant as a role of immunotherapy in the adjuvant treatment of advanced head and neck cancer patients receiving the chemoradiation therapy. So immunotherapy may be useful as an adjuvant therapy in the head and neck cancer receiving the chemoradiation for the better clinical response, a reduction in the side effects, and definitely improvement in the quality of the life. So this was being published in the for the patients of uh, recurrent and unresponsive non-muscle invasive bladder cancer. So this was the 20 patients with the non-muscle invasive bladder cancer. Patients received the intradermal injection of KD05, which was the earlier brand name of Mycidac-C. Recurrent free survival at 15th and 30th months was seen to be 35% patients, and a median recurrence free survival was also better with the BCG unresponsible compared to the BCG recurrent group with a hazard ratio of 0.329, and DSC3 desmoglin 3 expression was present in 68.8% of these cases, which has been correlated with the mode of action of Mycidac-C. So tumor infiltrating lymphocytes and recurrent-free survival beyond 30 months was seen to be 2.3 times and 2.8 times more often in the DSC3 expressing non-muscle invasive bladder cancer cases respectively. So with this, I would like to close here. So would like to close here, Dr. Mushidi. So would request to initiate your queries here. Your mic is on mute mode, unfortunately.
Yeah, please tell me.
Yeah. You couldn't hear, actually, your mic was on mute mode during that point of time.
No, it was unmuted now.
Yeah, please tell me. Yeah, queries.
Yeah, it's a nice presentation. Only two things I want to ask you.
Yeah, please.
Yeah, one is as you mentioned in your data that desmopolin 3 expression was negligible in adenocarcinoma as compared to squamous. It is expressive in around 86% of patients in
True.
large,
True.
around 11% of. But in the whatever the trial you mentioned where you got approval for Mycidac-C in lung cancer with combination with chemotherapy, cispacli, in that adenocarcinoma patients were also included.
True.
And for overall ITT population, hazard ratio was 0.64 with a p-value of significance. And subgroup analysis squamous, it showed 0.40. And what about the adenocarcinoma cohort? What happened to that cohort? Is that significant or not? Hazard ratios and
it is of course significant, but has been proven by the Dr. Chandra Belani publication as well. So talking upon like overall advanced non-small cell lung cancer, the advantages found along with the platinum pentatonic doublet here. But talking upon the comparison between the squamous versus the adeno, definitely squamous is going to be having the better response in comparison to the adenocarcinoma here, only because of the expression of the desmocollin 3 here.
So the drug is working irrespective of desmocollin 3?
No, it is not like that. But I tell you, okay, irrespective of desmocollin 3 it is working, but response is going to be better.
Amit, okay. So, I mean, basically, it is working best where the desmocollin 3 is expressed. Okay. So, during transformation of all epithelial cancer, some cancer will overexpress desmocollin 3, some cancers will underexpress, or there will be disappearance of desmocollin 3 expression. Now, when the desmocollin 3 is expressed, naturally, this is doing best. And that is why you are seeing best result in squamous cell carcinoma.
Yeah.
When the desmocollin 3 is not expressed,
yes,
when you give chemotherapy, that chemotherapy will bring desmocollin 3 on the surface of the cancer cells.
okay.
Okay. And then this desmocollin 3 expressing cancer cells will be killed by immunotherapy and chemotherapy.
Yeah, the chemotherapy is converting desmocollin 3 negative to positive cells.
Yeah. As long as chemotherapy is effective. Okay. Say for example,
already de novo desmocollin 3 overexpression is there. There it is showing very good results, and wherever the negativity is there, chemotherapy is making it desmocollin 3 positive cells, and whereby this Mycidac-C acting and actually conferring the results in that cohort also.
Good. That's the correct interpretation.
Yes.
Thank you.
Thank you. Thank you.
Now, see, the only catch is when you give chemotherapy, all cells will not respond equally, correct? Otherwise, we will be getting like antibiotics, 100% kill.
Yes.
So chemotherapy sensitivity depends on so many factors.
Yes.
So if the chemotherapy sensitive cells are there,
yes,
the efficacy will be augmented.
Yes.
Okay? And this conversion from desmocollin 3 to desmocollin 3 positive is seen even at a subtherapeutic dose. So even when you give a subtherapeutic dose, the desmocollin 3 will be expressed, but the tumor will not be killed by chemotherapy alone. But then immunotherapy will work synergistically with those and then kill those cells. That's the reason you are seeing improved response rate.
Yes. Yes.
Okay.
Yes.
Is that clear now?
Yeah. Yes. Yes.
But you asked a very pertinent question and you picked up the right threads.
Yes.
Any other?
And what are the actually apart from the routine chemotoxicities, what were mentioned, that is myelosuppression and GI toxicities, fatigue. Apart from that, what are the specific toxicities related to this Mycidac-C immunotherapy?
So Mycidac-C specific systemic side effects are not seen so far.
Okay.
Okay, because I mean, and I'll explain you why. So if you compare checkpoint inhibitors which are approved immunotherapies, they basically provide passive immune therapy. So when you give, and that's the reason you have to give large amount. So when you give large amount of checkpoint inhibitors, it reduces body's immune mechanism. It alters the body's immune mechanism at one go, correct?
Yes.
And then there's a significant reduction in immunosuppressive cells, which are also required for the body to behave normally. And that's the reason you get a lot of side effects like autoimmune diseases and all that, correct? Organ specific, non-specific. Now this, you are not giving in a high amount. You are giving it 0.2 ml or 0.1 ml.
Okay.
That does not go to the target directly. Okay. It goes to the lymph node, and then body reacts to this and generates its own response. And that's the reason it's called active immunotherapy. I'll give an analogy. So when you give a vaccine, okay, vaccine per se does not contain antibodies, correct?
Yes. Yes.
But it generates antibodies.
Yeah.
So same way, when you give Mycidac-C, Mycidac-C per se does not do anything on its own. So if I do ex vivo, Mycidac-C has no effect.
Yeah, it activates our own immune system.
Yeah. So
T cell
it
activity.
yeah. So it does a T cell activation, and this activated T cells will express desmocollin 3.
Okay.
And this activated T cells which express desmocollin 3, since they're activated and express desmocollin 3, they will kill cancer cells which express desmocollin 3.
Okay.
Okay. So
Yes.
in a immunotherapy, there is a concept that you have to have a synapse, immune synapse for killing to take place. So for an immune synapse to take place, you need both the cells to come together. There has to be synapse formation because of the adhesion. So desmocollin 3, so typically what you have is ligand and receptor, correct?
Yes.
So desmocollin 3 behaves as a ligand as well as receptor because it's a homophilic adhesion molecule. So desmocollin 3 expressing molecule will get adhered to desmocollin 3 expressing molecule. So now this cytotoxic T cells which express desmocollin 3 will go and get attached to desmocollin 3 expressing cancer cells, tumor cells. Now, because they are body's own cells, they have a capability to recognize which is a normal cells and which is an abnormal cells.
Yeah.
So they will not kill normal cells.
Okay.
But they will definitely kill abnormal cells.
Okay.
So that's how you don't see side effects, systemic side effects.
Okay.
Okay.
So to add here, like some cases of injection site reactions can be found here in some of the cases as a part of the immunological reaction. So what the oncologists are liking here is said to be the intravenous infusion of Mycidac here. So what they do, like they are giving the 8 milligram of dexamethasone as a pre-injection, and the patient need to wait for about 45 to 30 minutes or 45 minutes to 1 hour, and post that this 100 ml of normal saline containing the micromet W, this can be infused for the patients. So to avoid this local site reactions here.
Not only local site reaction, everybody, it is not easy for everybody to give intradermal because in the medical schools, we are not taught to give intradermal. We are taught to give how to give IVs, how to give intramusculars, correct?
Yes.
So, I mean, many of the paramedical staff and the medical staff do not know how to give proper intradermal because there are very few products which needs to be given intradermal. So inadvertently, they may not give it at a right position and right place. So to avoid all that, if it is desired, intravenous can be administered, but don't administer intramuscular.
Okay.
Okay. Okay. And then, I mean, like it is seen with a checkpoint inhibitors like pembrolizumab, now we have started seeing some information that even as a monotherapy, it is useful even in lung cancer.
Okay.
So Amit can give you details. So that's what, when you, before you joined, I was inquiring, is it published or not published so far?
So it is under the publication process. So Dr. Moshini would like to share here information upon the same. There was a patient who was having the age of 65 years plus, and was suffering from the stage 4 non-small cell lung cancer. And what oncologist did, like he started with the carboplatin for the patient and along with the nab-paclitaxel for the patient. So that patient could not tolerate the chemotherapy. So only option left for him, which he was knowing, was said to be Mycidac-C. So he initiated the Mycidac-C injection for the patient. So patient was came to that oncologist in the month of last 2020 May month, and when he evaluated the patient in the month of March here, so his all nodules, all metastasis has gone for the patient. So oncologist said like whatever has happened to the patient is only because of the Mycidac-C. So that case report we are publishing in the journal here. So at the moment we are preparing the manuscript for that particular patient, and sooner or later it is going to be published in the reputed journal. So it is under the process of publication at the moment.
So even in the second line and later lines also it can be tried.
Yeah, it can be used whenever you want to use it. Okay, so it is a choice of a doctor how you want to position and how you want to perceived advantage pass on to the patients. Because in cancer, nothing works 100%. Correct?
Yes. And one question. Before initiation of this Mycidac-C, that desmocollin 3 expression actually IHC expression is need to be looked. Is it mandatory?
No,
So it's
no,
only
no.
over.
See, this is only for a research. See, when we do research, we try to find out how it works, what it does not do.
Okay.
Correct? So for a lung cancer, I mean, as long as you are using a chemotherapy or any therapy which is likely to be effective, you can combine this two together.
Okay.
Okay.
So wherever the overexpression is there, it is working very good.
Yeah. So I mean, it is a question of
better.
Yeah, it is a question of how good is good. Okay?
Yeah.
Say if I'm a beggar, somebody will give me 5 rupee note, somebody give me 50 rupees note, and somebody will give me 100 rupees note. But as a beggar, I will always benefit whether somebody gives 5 or 50 or 100.
Yes.
Okay.
So, Dr. Bushi, we are having the approval of Mycidac-C in all cases of all histological types of advanced non-small cell lung cancer. So it can be given for any histological variety, anyone from non-small cell lung cancer.
And is it FDA approved?
No, it is Indian product. So how can FDA approve Indian product? But all the studies were done under IND approved by US FDA.
So is it mentioned in the whatever the guidelines oncology is following?
No, it won't come. Say guidelines are framed for the products which are available in the Western world, and this product is not available in the Western world. So you have to frame your own guideline.
Yeah. So actually, one thing is data is good only. Actually, in squamous cell lung cancer, we have very limited options. Only chemotherapy, immunotherapy, and immunotherapy all patients cannot afford.
Yeah.
So only chemo later lines we can actually try this therapy. More or less, it is also immunotherapy. The one how to actually convince the patients without FDA approval, without actually framing in guidelines. It is somewhat scary
question. Yeah, difficult question. But what you can tell them is that this is an Indian product and it's approved in India. I mean, on a different note, I mean, so many products which are approved.
Where can we check this was approved in India?
This is a DCC website. Yeah, even I can give you the DCC approval.
Yeah, if we want to show it to patient attendants,
that I can share. No, but it's with me. If you ask me to show right now, even I can show it to you right now.
Why? Because before initiation, better we can actually show it to the patient attendants that this is Indian approved. Then we will be in safe hands. Otherwise, people are searching for so many things. No.
Yeah, that's right, Dr. Mishni. Good afternoon. This is Rajiv Saxena, and that is what is our job. And I had this business of OncoCare for Kerala as the vice president. Now, that is what is our job is that to help you when you prescribe drug, it has been perceived not only by the clinicians but the patients also that has been approved. So DCGI approval in place. Just to let you know that it's been published very widely in the Indian newspaper context in 2014, 13, and then Lancet Journal later, and then presented papers. So anybody who would go to Google search from DCI approved drug indication for this Mycidac-C, they can search through Google, it will appear. As nowadays patients are searching for any product or any product prescribed, it is available there. It will also show that this product, Mycobacterium W, has been used for a variety of indications. It's not only lung cancer, sir. Happy to share with you, Dr. Kamar, who is the principal scientist who invented this drug, can stress upon a little more upon it. But then, sir, Indian doctors in India from last more than 6 to 8 months has been extensively using in COVID. Not only the COVID patient, helping them to stop cytokine storm, and even beyond that, in prevention of COVID also been used. There are a lot of paper data published. 4 days before only, sir, there was
Mushini, here is the approval of Mycidac-C.
Yeah, can I take this picture?
Here it is. Yeah, of course, I can share it to.
We'll send you,
They will
sir,
provide you.
original.
You don't
Yeah.
have to take a picture. They will provide you officially.
Yeah, thank you.
Dr. Amit, 1 second, please. 5 days before, if you go through and then read the newspaper, Times of India, there's a front page article published by Indian government, and then the body with Kedla Pharma works with, mentioned that the Mycobacterium W, which has been launched in India, has helped so many patients in large quantity in India for preventing patients getting into COVID. Or those patients being injected this product, they were safer and mortality rates was very, very low, almost negligible. So it's been used in bladder cancer also. I think Dr. Amit can even show that the basis remain BCG is being used. Happy to share with you, sir. It is now what happened is in the recent past, it is failure from the marketing side that we could not reach out to doctors, eminent oncologists like you, and then talk the benefit of this product on the scientific background. However, sir, in last 1 year, moment I took over, we started reaching out to multiple centers and doctors. Happy to share with you, it is approved in Tata Hospital, Bombay. It is approved in their protocol. Dr. Kumar Prabhash, who is the head of the lung cancer and thoracic cancer unit, he uses his entire unit usage. It has been approved in TNMSC. It is approved in GCRI, approved in Bhagwan Mahavir Cancer Hospital. It is approved multiple centers in GC, multiple doctors are using. Why? That like today we are discussing with you, sir. We requested multiple doctors to reach out and showcase this benefit. You just said very rightly that yes, wherever DSC overexpression is high, it works very well, and wherever the DSC is not there, but the chemotherapy induces DSC3 and it works there. So, I mean, thank you very much for making all of us easy to understand. What you said is easiest way to understand Mycidac-C, how it actually works. Thank you. I'm really thank you very much the way you have coined that thing. It's very important. And that's where, sir, this product is scores over. As Dr. Amit was sharing one of the manuscript he's just prepared for getting it now published, was also showing a single patient is used. Dr. Dattatreya in Hyderabad Omega have used it. Medanta Hospital, Dr. Ashok Vaid is getting used. So these are the doctors that we approached very, one by one. And then because of the COVID condition, we cannot go live webinars or the program. So we have took the route of webinar, reaching out to doctors like you and then spreading the positivity. Second thing, sir, as you said very rightly, is commerce cell or non-small cell lung cancer checkpoint inhibitors like Optitas of the world or Keytruda, 2.5 lakh rupees per dose kind of a therapy. And that too, I'm hardly 1.5% patient may afford or may not. So this product comes at around 5,000 rupees PFS. The entire treatment gets consumed at 50,000 rupees for all 6 cycles. And if it is giving 4 months advantage over other, so that the trial data was presented 3 months to 4 months advantage, sir, it is worth trying on these patients because paclitaxel cisplatin used to be 27,000 rupees some year back, which is now we are saying around 1,200 rupees. And I remember I entered into oncology. I was a very small kid in oncology when Dabur have launched paclitaxel. So nobody, I don't know, were you practicing that time or not, but no doctor in medical oncology were believing that Dabur, Churan Bejne, Chawanprash Bejne wali company can develop paclitaxel in India. And that become the leading company of India in oncology. So we are just looking forward, sir, doctors, eminent doctors like you start using, practicing and then see the benefit in patient. Just try to extend that and possibly we will emerge with our own data. the entire protocol, 228 patient designed by US FDA as per the IND protocol, and the trial been done accordingly. Dr. Chandra Bedani, who was the world authority in the lung cancer, he was the principal investigator. Right? He is in that program. Dr. Khamar was the principal, one of the investigator in the trial, and then that's the and the promises the published in Lancet those years.
And two questions actually. The whatever the patient population size is so small in the whatever trials mentioned.
So I'll come back to that. But before you go, can I have a sharing right so that I can show him something on his squamous cell?
Varun, please share.
Sir, already, sir. I've already given the post.
Done, sir.
So where is that my sharing? Okay, how do I share? I mean, share screen. Okay. Slides. Where is the slide?
Sir, meanwhile, Dr. Venkatesh, sir, actually, he's from Surya Global Hospital, Kakinada, sir.
Yes.
As you rightly briefed, Sir, I mean,
सर
sir
कर्सर
has
बीच में
got
लेके आइए
sir
कर्सर
has
बीच
got
में लेके आइए अपने आप आ जाएगा सर
सेव कर लो, अंदर से बाहर काट। Can you see it now?
Yes.
yes sir it is seen
Yes.
Okay, so this will give you an idea, like we were discussing, correct? So essentially, you have a desmocolin tumor cells which are there. You give chemotherapy, they start expressing desmocolin 3. Then you give immunotherapy, which will bring desmocolin 3 targeting immune cells into the tumor stroma, and then as a combination, you will get effect. Okay, so that's what we discussed. Now I'm just showing you data of a squamous cell lung cancer. Okay, and these are all ITT. I'm not talking about 4 cycles, correct? So now if you look at it, what is that? HR ratios, I mean, on the last column,
Yes.
0.64 pembro plus chemo, 0.96 atezolizumab plus chemo, 0.75 pembro plus versus chemo, correct? 0.63 pembro chemo, checkmate nivo 0.82, nivo plus ipli 0.63. Okay, and then it goes out. I mean, if you look at all this, in some of them the confidence interval goes out. Okay, then nivo ipli with chemo 0.62. Okay, M power, which is Seplimumab, which is recently approved, 0.53. Okay, come here and what you see, 0.55. Okay, now I mean the other part of the story, sample size is dependent on the efficacy. So majority of the tumors and the treatment have a HR ratio in the range of 0.7 to 0.9. When your HR ratio is high, you need significantly larger sample size. When your HR ratio is small, you need to have smaller sample size, correct? It's efficacy. You want to demonstrate efficacy. So if your efficacy is high, you can demonstrate with a smaller sample size. Like all blood pressure drugs, they get approved with the efficacy of reduction in blood pressure by 2 millimeter of mercury or 3 millimeter.
Sir, your slide changed. We are seeing now Zoom something.
Yeah, so I've stopped sharing. So
Okay.
if you want, I can continue that slide. Okay.
No, then you have closed this slide, but you have to put on stop sharing button.
I don't know what is happening.
Top up. On the top. If you go to the top panel on Zoom, it will drop down.
Something else is happening. Okay, stop share. Okay.
Yeah.
Okay.
Yes.
So sorry if you saw something on my computer because there are so many things open. I don't know what you saw and what you did not show. So many windows were open.
I was hoping I'll get some idea of manufacturing something new invention. That's what I expected out of scientists. And I'll create my own copyright.
No, that will not come that easily. Okay. Okay. So basically, I mean, as a regulator, what you need is efficacy data and a safety data. This product has a huge safety data because large number of trials are done with this product. So safety is not a concern. And efficacy, as long as you meet the efficacy required, products get approved. So larger the effect size, smaller the sample size. Smaller the effect size, larger the sample size. Have I answered your question properly?
Yeah, in first study, what you mentioned, cis set offside only in 2 arms around 20 odd patients.
No. So, okay, squamous cell carcinoma, I mean, if you look at it, we have a significant number. But even with that, see, I mean, we have done it in different ways. So whatever way you do it, I mean, it comes out statistically significant, whether I do ITT, whether I do per protocol, and same way for a whole cohort, it comes out statistically significant. The only thing where it does not come out statistically significant in a subgroup analysis is for adeno. Adeno, it does not come out properly for a subgroup analysis, because for that, since the effect size is small compared to the squamous, you need a larger sample size as a subgroup. And we did not have that subgroup with that significant number. Okay.
And any real world data you have? Any clinician treated some cases or how they responded? Any such type of data?
So, I mean, one data Amit gave you that as a monotherapy. I mean, patient responded very well. No, I'm just saying anecdotal, but then there will be people. I am not aware of what others have done and what they have, I mean, communicating.
Whatever the mechanism of action wise, I don't have any objections toxicities wise, but the data is not that much robust.
Yeah.
Actually.
So it is your job now, doctor.
Yeah.
My job is over. Once the product gets approved, I mean, people like you who generate more data, real life experiences, and share those experiences.
Yes. When it was approved, DCGA?
I think it is 2013, 14.
Yeah. July 2013.
Yeah, honestly asking why this molecule was actually not moved from.
So that's what. Yeah, so that's the reason I say it is people like you who are, I mean, have to take it forward. See, we did our job as a scientist. Then, as Rajiv said, marketing did not pay significant attention, went out. And then, if you remember, in 2013, immunotherapy was not a buzzword. So people were skeptical of immunotherapy. Now everybody understands immunotherapy, correct?
Sir, it was.
No, I mean, there are two parts to the story, Rajiv. In that time frame, if you go and ask the oncologist what is cytotoxic T cells, they will not know. They say we don't know that. We know what is chemotherapy does, what is, I mean, cell cycle and how the cell cycle behaves and all that. See, this science was emerging and not everybody was aware. So we should thank checkpoint inhibitors that they made it widely.
Sir, that's exactly. I happened to work in Roche when we launched actually the Herceptin in India and the Mabthera in India and then Zalodas of India. And trust me, sir, the India was getting into the understanding use of biologics and then biosimilars. So the use of biologics starting from early 2001, 2002 to 2007, 2008, the early biologics or launch and discussion was going on, wherein the overall access to the patient were not going more than 1.5%, 2%. And that point in time, Dr. Reddy's came in as the savior, the first ever biosimilar of rituximab being launched. So people were not believing even those. And trust me, sir, I was there and I see the data which went for the approval in DCGI for the biosimilar of rituximab was on 8 patient study. Only 8 patients was approved, and then subsequently they have done phase 4 with the help of Indian clinicians, medical oncologists, and then where the Ritux went down to. And then second breakthrough happened when I was in INTAS and we could break through of biosimilar of PEG-GCSL. And that is the point, almost 2007 end, their product been launched and then fourth in. And then after you see Biocon and other companies have emerged, and then the era started from 2007 to 2014-15 of biosimilars. That point in time, bevacizumab checked in, your cetuximab came in, and then early other product. And those days when the lung cancer was suffering, you got the TKIs. And then TKI, the Jafetanibs of the world, Arlotinibs of the world starting, and doctors are experimenting. And then blacks versus white, a lot of controversy got into, and then what are using. And that's where this product got launched. And that is where the marketing muscle was the maximum required to establish an Indian product versus all these, biosimilars, which was a 1 lakh rupees therapy gone down to 50,000, 30,000 rupees. You know what happened to biosimilars, right? And today maybe 10, 12,000 rupees of trastuzumab, which actually I launched in India, Hercept in 1,40,000 rupees a vial. So that's the change was happening. That point in time, sir, Mycidac came into India just because of the, as you saw, it has a FDA approval. So initially, a lot of questions in the mind, and then checkpoint inhibitors, so immunomodulation was not at all in discussion. The interferons of the world already gone out of the picture because they lost against the imatinib. So the magic bullet came in and the interferon dislodged completely and went to the Hep C and Hep B, and then the market was shifting completely. Thanks to the world of checkpoint inhibitors, the livolizumab and pembrolizumab coming in, and the doctors started believing again the immunomodulation, and then that's where things on. And meanwhile, this organization from 16 to 18, 19 lost that kind of a attraction to go to the medical oncologist or eminent oncologist practicing in the area and then discuss about this product and generate another additional Indian patient data by requesting you, reaching out to you, creating a CRF, helping few patients, generate few patient data, missed it. I happened to join, sir, here, and I worked for 10 years in Zydus Oncology. Before that, I was for 4 years in TAS, and before I was in Sun Pharma. Before also, throughout oncology, I was doing this only. So last year, when I started taking up, the unfortunate COVID happened, and we could not reach out to anywhere, and all the plans gone for that. So for the last 3-4 months, what we did is started, requesting doctors like you, please come on Zoom if we can discuss with you. We have developed the good team coming and meeting. Like Lalita has just joined. He is now meeting you. There was a vacantary. Nobody was there to reach out to doctors and meet. So now, sir, we are connecting the dots and
only one before we close. Only one last question. Apart from the whatever the drug was approved in lung cancer, apart from the lung cancer cell line, it was, as per the data, it was useful in head and neck cancer and bladder cancer.
Yeah.
Yes, sir.
Yeah. In that that desmocolin 3 expression was not mentioned.
It is there, but it is there.
Listen carefully. Listen carefully. Listen.
Okay. Sorry, sir.
Yeah. What is the actually maybe desmocolin 3 is only maybe that is the additional point that was looked in lung cancer. Maybe it is working irrespective of the desmocolin 3. So whether same head and neck cancer cell line, bladder cancer cell line, the expressing the desmocolin 3 only where there only it is working. I am getting doubt of in that aspect. Actually, what is it specific to desmocolin, or so we need to see for desmocolin, or is there any specific cell line where this is working, or is there any generalized statement for that?
Yeah. So okay. So let me answer one by one. Say what you are seeing is a success story. You are not seeing our failures. Okay. So our trial in prostate cancer, in spite of the fact that it provided significant relief from the bone pain, it failed to show mortality benefit. Our trial in breast cancer, though it provided a data that side effects of the chemotherapy is reduced, it failed to provide any significant benefit. So there are multiple failures. I mean, what we have learned is from a multiple failures. What you are seeing is a success. As is typical, I mean, failures are more. I mean, what you are seeing is the tip of the iceberg. Okay, so that's the first part. Now, as we grow, as we start to understand, as we learn the science, so what we did is we did two parallel things. We started working in developing this product for oncology since 2000. Okay, and then what we did is on one side we just kept generating clinical information, and on the other side we kept doing lab research. Okay, so both went parallel, and in that each one helped each other. Okay, so when there was a failure, we asked the question why it is not working. When there was success, we ask the question why it is working. Okay? And that's how the whole science and clinical development work together. Now to answer your question, where chemotherapeutic agent is used for treatment of epithelial cancers, where there is no epigenetic silencing. Okay, this will convert desmocollin 3 negative tumors into desmocollin 3 positive, and then it will show effect.
Wherever the
Now,
desmocollin overexpressed.
Hold on. Let me complete and then you come back.
One
so that you
question.
understand.
Actually, I got maybe irrespective of the cell line, wherever we use the this Mycidac in combination with chemotherapy, that chemotherapy is converting negative cells to positive cells.
Yes.
One question is wherever already desmocollin 3 overexpression is there, can we avoid the chemotherapy?
Okay, so we have not done that study.
Only can we push Mycidac-C only?
No, that's what I'm coming to that. See, we have not done that study in principle for a large size tumor. And for that, you have to understand, okay, so we have a data which says that it works in a bladder cancer where desmocollin 3 is expressed, and that is published. So, I mean, somebody can share that article with you.
I have got links. This is 68%. Yeah.
Amit. So, BCG recurrent bladder cancer is a problem. So when we were talking to US FDA suggested that rather than working everywhere, generate some data on BCG recurrent bladder cancer. Please stop your sharing screen, Amit. Okay, so we did that study and that is now published. And during that process, we realized, because it was not known before, that desmocollin 3 is expressed in bladder cancer. And we are actually in the process of writing up an article on desmocollin 3 in bladder cancer. Okay, so we have done a lot of work, not only immunohistochemistry, we have used bioinformatics, used microarrays. So we are trying to do that, and that gives a different image, which I'll share with you a little later. So there it works as a monotherapy alone. In a melanoma, advanced melanoma, this study was done in USA. It works as a monotherapy. Okay, so there are information in the lung cancer. Amit shared one anecdotal data. So it is not that it has to be given, but then if you give a chemotherapy, the chances of success will go high. And then if you are a little more familiar with immune mechanism than chemotherapy, I can go in little more details if you want and give you a little more insight into it. So if you know that, I mean, chemotherapy, I mean, all the trials done for checkpoint inhibitors. So Pembro divided groups into major two parts. Those who express PD-L1 more than 50%, they use this as a monotherapy.
My doubt is only after if clinician exhausts with multiple lines of chemotherapy, if he wants to use only monotherapy of Mycidac,
you can.
So if that cell line that doesn't express the desmocollin 3, maybe it is not going to be useful as a monotherapy.
Yes, that's the right answer. That's the right answer. So what you should do is, if you want to do it as a monotherapy, try to get the biopsy
and desmocollin 3 expression.
And if it is, yeah, go ahead.
Yeah, and yes, and one more doubt actually, what about the CNS penetration of this Mycidac-C?
Is 100%, because immune cells go everywhere. Cells go everywhere. Okay.
Okay. And what about the actually intradermal? It is going to be actually deliver difficult.
Yeah, so that's the reason we said you can give intravenous.
What is the dosing for intravenous?
Same dose. You don't change the dose, but intravenous gives you flexibility to increase the dose, which we, for lung cancer, we don't recommend, but you can increase the dose also.
Okay.
But the only catch is, because it's a biological, which is given in a large amount in a single shot, so there is a potential of infusion reactions. To avoid those infusion reactions, which does not happen in everybody, there's a potential to have an infusion reaction. To avoid that, just give 2 cc of dexamethasone or equivalent steroid, and 1 hour later give this. And that you can give directly slowly, or you can dilute in saline and give it. Okay. And I have personally given as high as 5 ml of Mycidac-C, not 0.1 ml or 0.2 ml. Okay.
And wherever this desmocollin 3 overexpression is there, in such situation, can we avoid chemotherapy?
I will not recommend going against the wisdom. Okay, but what you can do is, okay, I'll tell you what you can do is what Seplimab story has done, and that's what I was hinting at. So conventionally, everybody does 4 cycles of chemotherapy or 6 cycles of chemotherapy. In a Seplimab lung cancer trial, they got approval from FDA to do only 2 cycles of chemotherapy. Okay, so after 2 cycles, if you're satisfied with the response, then you can take those risks.
Okay. And one last question.
And then you have to understand the other part. See, when the tumor is large, which is typically large when you have only option,
Yeah.
at that point in time, there's a immunosuppression also.
Yeah.
So you have to get rid of immunosuppression for the immunotherapy, active immunotherapy to be effective.
Yeah, why I am asking in locally advanced head and neck cancer, you said combination with chemotherapy. So it is going to be a toxic regimen.
Yeah.
Radiation along with chemotherapy, along with the Mycidac-C.
So in that, okay. So now if in head and neck
Wherever
cancer, you have got-
overexpression is there, can we avoid that weekly cisplatin? Can we give only immuno plus radiation?
yeah. So if radiotherapy plus immunotherapy is okay, and on the top of it, if the tumor is reachable, approachable, you can give intralesional therapy, which will enhance the efficacy of the Mycidac-C. Okay. So rather than giving intravenous or intradermal, you can dilute it, say 0.1 ml, dilute it to 1 ml, and then give at a multiple locations within the lesion. And that will give you the best result. Okay. And that will not have a side effect. Okay. So radiotherapy and immunotherapy alone is okay.
Okay.
Chemotherapy and immunotherapy alone is okay.
Okay.
Immunotherapy alone, if you want to try, make sure that you have a significant higher.
And, yeah. What is this desmocolin 3 actually function? What actually it does in the
body? So desmocolin 3 is an adhesion molecule, which is present in your skin and my skin also. So it's a normal, naturally occurring adhesion protein, which is typically seen in desmosomes. If you remember your biology, the cell gets attached to the adjoining cells at the desmosomes and at adherence junction. At adherence junction, you have E-cadherin. At desmosome, you have a desmocolin and desmoglin. So, and then there are 3 varieties of desmocolin and 4 varieties of desmoglin.
How actually it results in the cancer development, where it actually involved in the tumor development and progression is this desmocolin?
So desmocolin 3 being an adhesion molecule, it initially, when it is normal, it allows tumor to grow locally. Okay, does not allow to metastasize. But then there are certain changes takes place, and then it is also there in the metastatic lesion.
Okay, maybe in the
Yeah.
Okay. Thank you.
Okay. Thank you. Nice talking to you. But I mean, feel free to reach me out for any questions, because I like the way you ask me the questions.
Sir, just 2 minutes. Dr. Venkatesh, sir, he's with Kakinada Global Hospital, sir, Surya Global. Like I can say, this is an hospital which is taking care of entire coastal Andhra today. Yes. Here, the maximum patient are Arogyasri, but not Arogyasri, affordable Arogyasri patients, because Andhra government has given all the patients for Arogyasri card. But here the patient, probably the patients are very affordable, and their OPD itself is more than 100, and this is per day, sir. And Dr. Venkatesh sir had a few things to be clarified. I hope so, sir. Everything has been clarified. As Rajiv sir said, sir, it's only from past 4-5 months we have initiated these programs, and within these 4-5 months, actually Tata, after the COVID, it has opened. In that itself, in a month, we have got around 30 patients enrolled for Mycidac-C, sir. We have got HCG approval, and in HCG already 3 patients has been given Mycidac-C in HCG Bangalore. And Miyot Hospital, Chennai, there is 3 patients who have been enrolled already. And Dr. Prem Kumar sir, as he works for government institute like TNMSC, he has enrolled almost 5 to 6 patients in Chennai. And also Dr. Dattatreya sir has enrolled 1 patient, and Dr. Bharat Patodia, Dr. Vamshi Krishna. These are all the doctors which has been doctors who have enrolled the patients in these 3 to 4 months. As rightly said by Rajiv sir, it was not there. There was a gap. Now it has picked up very well. And if you can name, sir, Dr. Kumar Pravash, Dr. Ashok Vaitsur, I can say even Mumbai. Actually, we have Dr. Sachin Elman as well as Dr. Boman Davar, sir. All have shown the interest, and they have been enrolling the patients. So this is how it has been said, the journey.
Sir, it is unfortunate that after developing any molecule in India or doctors, how many companies in India actually take that kind of innovation route taken up, but unfortunate that the marketing and sales team is unable to reap out the benefits of such endeavors, and especially when Dr. Bakulesh Kamar himself is present, taking his wisdom, knowledge, and interact with doctors, leaving aside whether patient comes or business comes or not come, whether it become grand success or not success, but something which is invented in true sense, if you are unable to take you through with the science of the product and put you across that, okay sir, we live up to your choice when you are the eminent doctor, you understand science well, you know patients well, and you know the Indian demographics and economic conditions, whatever not, wherever you think that is suitable use, and you check and then you develop an interest and confidence, then only can go up. So why to deprive such patient population who are just dying because nothing is available untimely? So I think it's a very big failure on the part of the people who have not worked out. However, sir, I feel elated and happy that I'm able to reach out to doctors like you, and thanks Dr. Kamar to taking out his time and coming to sales and marketing people and then trying to describe and give them 1 hour, 2 hours time like this. It takes a lot of pain, sir. Every time one doctor, two doctors discussing, you go in one conference, 100 doctors comes in, and then 1 hour your job is finished. But then like this, sir, we are doing almost every alternate day, and he is kind enough to accept our invite and putting his energy on it. So thank you, Dr. Kamar, for really taking us, all of us through. So it's keep on reminding me also that no, I need to do little more effort, and request doctors to understand product better and let us know what is your experience, and then if you can extend this benefit to your patients, they may give all of us blessings here. Yes, one of their patients survive better and with the lesser cost. That's the only thing that we are looking for. Thank you very much accepting our invite, joining in, and looking forward to assist you better wherever best possible. Thank you.
Before you leave, I mean, Dr. Munshi, you asked for a terminal patients, correct? So my suggestion is, I mean, for a terminal cases, you give a palliative radiotherapy along with Mycidac-C, and that is likely to improve your chance of success. Okay, not the full dose, 20 GY spread over whatever time frame your radiologist or radiotherapist is giving, and then along with it start Mycidac-C. You are likely to get better results. Like I'll give you example. My own uncle, he had an advanced bladder cancer which had come out of the bladder wall, and everybody condemned him to the death. And then he approached me, and then they said since he had a hematuria, he was advised palliative radiotherapy. The tumor within the bladder was 9 centimeters big, so you can imagine what was with ultra. Okay, and then he received 20 GY radiotherapy as a part of palliative therapy, and I gave him Mycidac-C every 2 weeks, and within 2 weeks the tumor was not there. And then the radiologist who was examining him, he says, I don't find a tumor. So I took him to another friend of mine and asked him that he had this size of tumor. Now you have to give me where is the tumor. Okay. So those kind of dramatic results are also seen. But if possible, try to give a radiotherapy at least to the largest region, palliative. Okay. Okay. Thank you.
Thank you. Thank you.
Thank you very much. Nice time. Stay safe, stay happy, sir.
Thank you. Thank you.